Next version.
How we showed up there, we're like,
we both
yeah, and so they have
Okay, good morning, everybody. I just got the news that you have an exam today after this class. So if it's okay with you, we just skip the break time and we finish at 9:15, 9:20 or so. So you can have some time to get rest or study for exam. So please bring the slides for chemotherapy and related toxicities to chemotherapy agents. As general, when we are talking about cancer, I just wanted to go over a couple basic or principles about pathology of cancer or what things are important to us. Why? Because when we wanted to make medication or when we want to design medication, we want to use medications to treat, cure, or have a palliative care of cancer, we should know what we are targeting. What genes, what proteins, what cells we are targeting. This way we have treatment with minimal adverse drug reaction. So that's very important to us to know about pathophysiology of cancer. So when we talk about cancer or molecular basis of cancer, we are talking about basically two very important genes. One type of the genes are oncogenes. And the other type of the genes or proteins are tumor suppressor genes or tumor suppressor proteins. As you know, any protein in our body, when the protein wanted to be synthesized, there is a gene for that. So we have a gene for cancer proteins, cancer-related proteins, or cancer cells, and also we have genes for proteins that suppress the cancer cells. So if you want to design a medication, I want to ask you, if you're going to design a medication today, what do you do? What do you do with oncogenes? Do you want to suppress them or do you want to enhance them? Oncogenes? Suppress them. So you make medications that target those proteins, target those genes, and suppress them. Okay? The opposite with tumor suppressor genes. You want to enhance them. In the past, we didn't have such a technology. So up to, let's say, 15, 20 years ago, all medications, all chemotherapeutic medications were just toxic medications, pure toxic medications. They just kill the cells with high proliferation. So any cell line with high proliferation rate, like hair follicles, skin, cancer cells, white BCs, RBCs, those medications just kill them. So a lot of good things, a lot of good effects because they kill cancer cells. At the same time, they kill a lot of good cells, like hair follicles, skin cells. So a lot of cancer, a lot of adverse drug reactions. But if we can target these, we have minimal adverse drug reaction. Because you kill only the genes or only the cells that have the proteins that are cancer proteins. Okay, that's much targeted treatment. Of course, one of the major disadvantages would be cost, because it takes a lot of energy, it takes a lot of resources to make medications in these classes. Okay, some of the oncogenes. These are not all oncogenes, but these are some of the major oncogenes that I want you to remember them. Just remember the acronyms. I don't want you to remember the whole name or in which cancers we have these oncogenes activated. What I want you to know is in the test, if I ask you which of the following genes are oncogenes, you pick one of these if they are in the test. So these are the genes, these are the proteins that we are targeting to inhibit. We want to inhibit this. I'm sure if you look at the TV, sometime if you have time, and there are some medications ads for breast cancer, and they said for HER2 positive, look at the second bullet, HER2 positive. It means HER2 is a growth factor. So if the breast cancer, if the cells are sensitive to this growth factor, we have a medication for that now. Like 20 years ago, 30 years ago, we didn't have medication. But now we have a medication that specifically targets HER2 cells. Any cancer cells that has this protein on the surface, we can target it and kill it without damaging other healthy cells. So this is good. So basically, for the test, the question can be, are we want to enhance this or inhibit this? And the answer is we want to inhibit these proteins. And the other question would be, which of the following is an oncogene? And if you see any of these, you pick those. The opposite would be tumor suppressor genes. So exactly the opposite. If you are a scientist right now and you wanted to design a medication, you want to design a medication to activate these genes. Like P53, if you activate these genes, we can suppress cancer cells. And all others. These are all cancer suppressor genes or proteins. So again, for the test, if the question is, if you want to inhibit or enhance this, we want to enhance this. And if I ask you which of the following is tumor suppressor, you pick one of these. So in the test, you may have a number of these acronyms or these acronyms. I just want you to recognize which is which one. Okay, other definitions that are important. I want you to remember, and I'm sure you probably had this in other courses, like in pathology, if you have pathology, okay, oral pathology. So when we are talking about hyperplasia is not necessarily cancer. As you know, hyperplasia is an increase in the number of the cells in a particular tissue or organ, which results in increase in size and number of the cells of that organ. A very good example is what? Somebody said that. Very good. Gingival hyperplasia. Is it cancer? No, it's not cancer. Gingival hyperplasia induced by nifedipine. Very good. Depends. Do you remember calcium channel blockers? So if you have a patient with hypertension and the patient is on one of the calcium channel blockers, you want, this is a must, as a dental professional, you want to check the gingival tissue to see if the patient developed gingival hyperplasia. If that happens, what would be the best solution? Very good, to switch medication. So the best recommendation then to the physician or to the patient is go to your physician and talk about it. And if the physician asks you, the best solution is to discontinue the dipine and switch to another antihypertensive medication. If I switch nifedipine to amlodipine, it doesn't help. It's still there. So hyperplasia can be caused by medication, can be caused by other triggers, can spontaneously be developed like hyperplasia of the tissue, but it doesn't mean it's necessarily malignant. Dysplasia is abnormal change in size, shape, or organization of cells of the tissue. So it's just abnormal shape or abnormal change in size. It can be either the cells become bigger or smaller or shrink, so it's just abnormal. So that's dysplasia. And when we are talking about neoplasm, neoplasm can be the result of dysplasia or hyperplasia. So neoplasm is just increase in the number of the cells. Again, we are still not talking about malignancy. A neoplasm or a tumor, we can call that tumor. Neoplasm can be benign. Benign neoplasm is the cells are a lot, but they are still functioning. That's very important. The difference between benign tumor or benign neoplasm versus malignant neoplasm, as you know, is in malignant neoplasm, we do not have functional cells. So if we have liver malignant neoplasm, we have a lot of liver cells, hepatocytes, but they are not functioning. It's just a tumor without function. It's not good. The other bad thing, the other major difference between malignancy versus benign is benign tumor, usually they do not have metastasis. They do not go far. They do not go to blood vessels or lymph and get to the distant side. But in malignancy, we have metastasis. That's very, very important. Okay. Another difference would be after being removal, the benign tumor usually does not recur. The malignant tumor may recur. So there are some differences that I want you to know, the differences between benign and malignant neoplasm. Okay, I just mentioned here again, in malignancy, for example, we have a kind of like bone marrow malignancy. So the patient has a lot of white pieces. When we measure the white pieces, the neutrophils, they are a lot. They are like, what is the number of normal? What is the normal range of neutrophils? 1.5 to 8. 1.5 is the lower, very lower end. Yes, but around that range. Let's say 4, 5, 6,000, okay? But when you're talking about malignancy, you're talking about hundreds of thousands. So the blood is so viscous with a lot of cells. It's not good. But at the same time, the worst thing is those cells are not even functioning. So if there is an infection somewhere in the body, those neutrophils, those 100,000 neutrophils are not even functional. They are just there. If the patient has a lot of platelets, they are just there. They do not inhibit the bleeding. So that's the problem with malignant cells. Treatment modalities for cancer, as you know, again, one of the major modalities to treat or cure, in some cases even to cure the cancer, is surgery. There are some tumors, especially solid tumors, that we can just, if we know the borders, if the cancer is still in the tissue, if the cancer is not metastasized to distant, we can just remove that whole tumor. And if the surgery is under advanced technology, like microsurgery, the surgeons can see the borders and define where they can cut the tissue that there is no other cancer cell beyond that. So that's one way. We still use surgery a lot. Radiation, another major modality. A lot of time, surgery is not possible, so we have to go with radiation plus minus chemotherapy. A lot of times, surgery is there, so we remove the tumor, but we wanted to make sure that the rest of the cells, if there is any remaining cancer cell, is gone. So we do the radiation. 1, 2, 3, or 4, or whatever. The radiation oncologist thinks it's better. We have courses of radiation for patients. Of course, with radiation, it's also a lot of damage to other cells. So when we are talking about head and neck radiation or chest radiation, again, back to your profession, there are a lot of damage to dental and oral tissue that you need to monitor the patient. Can you name, or can you give me one of the examples of major damage to oral tissue? Xerostomia is one of the first one. It's one of the most common one. Severe xerostomia. So patients after 1 or 2 courses of radiation therapy come to you and they have dry mouth. And it's very severe. Because unfortunately, in some cases, extensive radiation or extensive chemotherapy can kill the salivary glands. So there is no more salivary glands. So even if you give the patient pylocarpin, which is what? What class is pylocarpin? What does it do? Do you know pylocarpin? I'm sure we talked about this. We talked about this. Last quarter. I have xerostomia today, I don't know why. I think I got antihistamine last night, so. First generation H1 blocker, xerostomia. I knew that. So, back to pylocarpin. Pylocarpin is cholinergic agent. It's cholinergic agonist. So it causes salivary glands to basically secrete more salivation. So if the patient has salivary glands, we can give the patient pylocarpin to treat xerostomia. But if the patient has courses of radiation or chemotherapy and salivary glands are totally dry, there is no more salivary, there is no more cell. Even if you give the patient pylocarpin, it doesn't help that much. Traditional chemotherapy. In a few minutes we talk about traditional chemotherapy agents. They are purely toxic agents. So whenever we are talking about traditional chemotherapy, toxic. They are just toxic to the cells, especially toxic to the cells that are highly proliferative. Like again, skin, GI mucosa, like hair follicles. So we are talking about toxic medications. And when I talk about toxic medication, it doesn't necessarily bad. I don't want to give you a negative view of chemotherapy. It's toxic, and sometimes we use toxic medications to cure. So sometimes we need to use them. Targeted drug therapy is a very hot topic in pharmaceuticals these days. So we try to target the cells that we want to kill them. So if we wanted to inject chemotherapy, we don't want the chemotherapy agents go everywhere in the body and start hurting all tissue. We wanted to tag the cancer cells first, so we inject some medications. The only function of them is go to the cancer cells and tag them. And then when we inject chemotherapy, the chemotherapy agent just go there and bind to those tagged cells. So that's more targeted. And the adverse drug reaction is lower with this technique. Of course, again, whenever we are talking about more targeted, biological, less or controlled adverse drug reaction, of course we are talking about more expensive medications. And biological therapy, again, this is a recent evolution in pharmaceutical medication design, that we are making proteins very similar to our body proteins. And those proteins can inhibit cancer cell growth. So these are all different modalities of treatment. When we are talking about chemotherapy, please, almost all these slides are important. I mean, for chemotherapy in the past, I used to have a lot of slides, and then a student didn't like it, and then I have to go back and say, this is important, don't worry about this slide. This is a shrinked version one. So I already just removed a lot of information that I think it's not necessarily important for you for the test or for your board. These are the material that I definitely ask questions. So everything here on these slides can be a good one question for your test. And a lot of them are important for you for practice, and the reason for that is a lot of physicians, a lot of oncologists refer their patients to you or dentists to check the oral tissue, to make sure before chemotherapy, before radiation, the patient has a healthy tissue. Because after radiation and chemotherapy, there's a lot of damage. So they send them to you to make sure everything is okay before they start the regimen. Okay. A couple more terminology. Adjuvant therapy. Adjuvant chemotherapy is the systemic chemotherapy after localized treatment. What it means is we remove the tumor with radiation, we burn the tumor, or with surgery, we cut the tumor, and then we give the chemotherapy. So it's a very traditional way of treatment. We remove the tumor, we remove the cancer cell, and then we give the chemotherapy to make sure there is nothing left. This is adjuvant. Neoadjuvant therapy is what? The opposite way. You give the chemotherapy first. Why do you do that? Very good. To shrink the tumor, to make it smaller. So we give it chemotherapy, it's toxic to the cells, it makes the tumor smaller, the borders are more defined, and then the surgeon cut in and get the tumor out. So that's the opposite way. Let's see if there is, yes, adjuvant and neoadjuvant. Okay. Okay, let's start with some of the major classes of chemotherapeutic agents. Again, when, for example, I'm talking about antimetabolites, the list of antimetabolites are at least 10 or 12 medication. But these are the antimetabolites that you need to know, because these are the most commonly used antimetabolites that you may see sometimes in other texts or in your board exam. So in general, whenever we are talking about this class of chemotherapy agents, we are talking about the agents that affect the genomic material, like the DNA. They are similar to nucleotides. So they start the replication and protein synthesis. Major medications are 5-fluorouracil. 5-fluorouracil. Sometimes you may see the acronym 5-FU, 5-fluorouracil. So in the test you may see the acronym. Cytarabine is another antimetabolite agent. So please just remember the names, because in the test I may ask you which of the following agent is antimetabolite. And the other one is methotrexate. One more thing about methotrexate I want you to know is it's antimetabolite, yes, but in addition it's antifolate. So methotrexate prevents the activation of folic acid in our body. So that's very important, because you may see it again and again in oncology and in rheumatology courses, or texts or topics. So methotrexate is antifolate. It is still below the big umbrella of antimetabolites, but in a specific, this agent is antifolate. Okay, methotrexate can be used in both cancer. In cancer, let's say if somebody has bone sarcoma, or sarcoma of the soft tissue, a tumor in nasopharyngeal space. So you see the patient comes to you, the patient has a lot of congestion, a lot of time they get confused that they have sinusitis or something like, or allergy, but after pathologic test, the result is no, there's a cancer there. So if you wanted to give them methotrexate, the dose is very, very high. We are talking about grams of methotrexate, 4 grams, 5 grams, 6 grams of the medication in 2, 3, 4, 5, 6 courses. Another use of methotrexate is in rheumatology. If somebody has Crohn's disease, if somebody has inflammatory bowel disease, if somebody has rheumatoid arthritis, which is autoimmune disease, we also use methotrexate. But the major difference is the dose for methotrexate for those patients is milligrams. So you may see those patients, you look at the medication profile, you see methotrexate is there, and the dose is 2.5, 5, 10, 20 milligram per week. Just compare it. 20 milligram per week versus 3 grams or 4 grams each time for cancer. So the reason I say this to you is sometimes we see the methotrexate in patient's profile and say, oh my God, this is toxic medication. No. A lot of times, if you look at the dose, you can realize this is not for cancer. This is for rheumatoid arthritis. So it's very low dose, tiny dose to just control the immune system. So the indications would be different. The other important fact about methotrexate is I may ask you about the antidotes. There are 2 major antidotes for methotrexate. One is leucovorin. Leucovorin is an activated form of folic acid, vitamin B. So it's an antidote for leucovorin, for methotrexate. And the other antidote is glucarpidase. So for the exam, please know both agents. for the most part, if they ask question about antidote for methotrexate, it's Leucovorin. But also glucarpidase is another antidote for this agent. Do you remember of any other vitamin to be an antidote for an agent?
Vitamin D.
Vitamin K. Very good. For what? Warfarin. So sometimes we use vitamins as antidotes for some medications because those medications are anti that vitamin. So in this case, methotrexate is anti-folic acid. So if we give the patient active form of folic acid, which is leucovorin, we are basically clearing the effect of methotrexate. Vinca alkaloids. Vinca alkaloids are among a group of medications, a group of chemotherapeutic agents that we call them microtubule targeting drugs. Do you remember microtubules? Where they are important? Do you remember? Cell, intracellular transport, something else.
Cell reproduction.
Very good. Mitosis, cell replication. So whenever we are talking about mitosis, cell replication, we are talking about microtubules. Do you remember? They are between the centromeres and then the genomic material get divided. Okay? So there are some of the chemotherapeutic agents that specifically target the tubules. So the result would be the prevention of cell division. And that's exactly what you want in cancer cells, to inhibit the cell division. Okay? So among those agents, there are some Vinca alkaloids. So in the test, if I ask you which of the following is an inhibitor of microtubules or a Vinca alkaloids, I want you to pick one of those Vincas, or Vin. Vinblastine, vincristine, or vinorelbine. One of those, and they're easy because they have VIN at the beginning. The reason I ask you to know this is because these are very commonly used medications in many different types of cancer, including lymphomas, or bone marrow related or lymph related tumors. The other subclass under microtubule targeting drugs are taxanes. And again, it's easy to know which of the following is a taxane or which of the following is anti-microtubule. Paclitaxel, tax, and docetaxel. So you pick those medications. So all these Vin and tax medications are under the big class of anti-microtubule agents. So the main function of them is inhibition of cell replication. Topoisomerase inhibitors. Topoisomerase inhibitors, they inhibit the enzymes that help DNA replication. If we inhibit that enzyme, the DNA cannot be replicated. So the cell division is interrupted again. Among topoisomerase inhibitor, we have etoposide. The very first one, etoposide, is the agent that is anti-topoisomerase. And anthracyclines that are doxorubicin, rubicins. Doxorubicin, daunorubicin, idarubicin. And ticons, like irinotecan and topotecan. So ticons, rubicins, and etoposide are among topoisomerase agents.
Can you repeat that?
What's that?
Can you repeat that?
Yeah, actually, if you look at the top, these agents are all topoisomerase inhibitors.
Oh,
So if I ask you which of the following is topoisomerase inhibitor, you pick one of these, if you see these in the test. Any of these agents, etoposide, doxo, dona, and idarubicin, irinotecan, or topotecan. Are these agents used commonly? Yes, very commonly used. If we are talking about colon cancer, lung cancer, ovarian cancer, we use them all the time. We see them all the time. Breast cancer, like lymphomas, different types of lymphomas. Okay, another major class of chemotherapeutic agents alkylating agents. What do you think they do? Alkylating agent. They do not change the pH. It's alkalining agent. This is alkylating agent. What is alkyl? Chemistry? You hate that?
Functional group.
Alkyl can be metal or ethyl, like CH3, C2H3, metal group, ethyl group. So these agents, basically what they do is they just add or take a metal group or ethyl group, an alkyl group, from the DNA material. Very, very small change. But we call this mutation. They cause mutation in the DNA. And that mutation is extremely damaging. The mutation is extremely toxic. So these are alkylating agents. The very first class would be nitrogen mustard. Mustard. What does it remind you?
Like a hot dog.
Mustard gas? Chemical bombs? They are. Not these medications necessarily. But in the past, like during, I don't know, World War I or World War II, they used mustard gas as chemical weapon. And unfortunately, in some countries, in some labs, they are still working to make these kind of weapons. So if the person inhales these, or if the skin is exposed to these, it's a very severe, quick mutation on the cells. No, sorry, what's that? Mutation, yeah, change in the DNA. And that mutation, since it's a mutation, it passes to the next generation. So if somebody gets that kind of severe mutation, it can be passed to the kids and the grandkids, unfortunately. But at the same time, in medicine or in pharmacy, they make a good use of these. So they make them as, or they work on the chemistry of these chemicals, and they make them as medications. We can use them to kill cancer cells. But remember, if we give high-dose ifosfamide or high-dose cyclophosphamide to a patient to kill osteosarcoma, it just does not kill the cancer cells. It makes a lot of damage to the GI lining, to skin, to bone marrow. So that's why with chemotherapy we have some major adverse drug reactions that we need to monitor. So please know the nitrogen mustard and also know the platinum derivatives. The platinum derivatives are easy to remember. They have platin in the name. So cisplatin, carboplatin, and oxaliplatin. So do we use these agents? We use them all the time. If you go to oncology wards or cancer centers, you see these agents are being used, infused for the patients all the time in different types of cancer. Okay, some of the more targeted medications are BCR-ABL inhibitors. So, can you tell me BCR-ABL, is it an oncogene or tumor suppressor agent, gene? Oncogene, very good, because what we are using is an inhibitor of that. So we are inhibiting an oncogene with some medications like imatinib, dasatinib, and others. So these medications, and a good thing about these medications are mostly they are oral, they are PO, they are tablets. So patients take a tablet on daily basis or weekly basis, and that tablet goes and just target these genes, just target these proteins. So much fewer adverse drug reaction. Okay, so what I want you to know about this slide is just know the names, and it's easy because they have tinib or inib at the end, and these are all targeted medication. I do not necessarily ask you these are BCR-ABL inhibitor or not. I just want you to know that these are targeted oncogene, anti-oncogene protein, or medication, sorry, targeted anti-oncogene medication. We also use some monoclonal antibodies. MO is monoclonal antibodies. So these are antibodies that we use, we inject in the patient blood vessels. They go and bind to some lines of the cells. So if the patient has lymphoma, the patient has a lot of lymph cells, lymphocytes, we wanted to get rid of that much of lymphocyte. So we use rituximab, for example. Rituximab binds and finds the cells with a marker, which we call CD20. Those are lymphocytes. And those are B cells, lymphocytes. And it just kills them. So on this slide, I'm not going to ask you which one does what. Like, I do not ask you trastuzumab is targeting HER2 cell, HER2 receptor. I just wanted to ask you, or I just want you to know that these agents are all monoclonal antibodies. Okay? By the way, trastuzumab is one of the major therapeutic agents against cancer, breast cancer. And that was a kind of like revolution in breast cancer treatment. So if the patient has HER2 positive cancer, HER2 positive cells, we can easily target those cells and kill the cells. Extremely effective for patients who have HER2 positive cancer. And recently, about 2 years ago, 2 medications came to the market that are specifically for HER2 negative. So it's a good news. Even if the patient has HER2 negative cancer, we still can target those cells. Okay. We also use some cytokines. Cytokines are part of our immune system endogenously. We can make them as medications. So immune system usually fights with cancer, fights with infection. So sometimes we develop cytokines and give it to the patient, and those cytokines, just like army forces, they go and fight with cancer cells. And a good example for that would be aldesleukin, which is interleukin-2. We have interleukin-2 endogenously in our body as a part of our immune system, and the medication is aldesleukin. Where do we see that? A lot of time in renal cancer cell. So if the patient has kidney cancer, we remove the kidney, and after removal, that's the decision of oncologists if they want to give the patient some doses of aldesleukin or not. Okay, let's about cardiotoxicity. So we talked about major classes of chemotherapeutic agents. Now let's focus on toxicities. Number one toxicity that I want to talk about today is cardiotoxicity. And the cardiotoxicity that I'm going to talk about is mostly in the form of heart failure. So if the patient receives these medications after certain number of the courses, after certain amount or milligram of the medication, the risk of cardiotoxicity or the risk of developing heart failure is much higher. So if I ask you which of the following medication has higher rate of cardiotoxicity, you pick one of these. One of the rubicins. So rubicin, cardiotoxicity. These are some of the risk factors for developing cardiotoxicity in those patients. So if the patient is receiving doxorubicin, and if the patient has radiation, chest radiation or mediastinal radiation at the same time, of course there is more damage to the chest, to the thoracic cavity, and to the heart. If the patient has pre-existing cardiac disease, so the patient has heart failure already, or the patient had an MI in the past, of course the risk is higher. If the patient has hypertension, extreme ages, and other cardiotoxic medications. So please in the test pay attention to these risk factors. Next major toxicity, as you all can predict and you all know, when we talk about chemotherapy, can you name 2 major toxicities that all patients hate chemotherapy for? They don't like chemotherapy because of two major side effects. Hair loss, number one. What's that? Taste alteration. It's not that bad. Nausea and vomiting. Especially in the past, chemotherapeutic agents, because we didn't have that many good anti-emetic agents, so when the patient received chemotherapy, they had extreme, severe nausea and vomiting. And it was really hard. They lose a lot of weight, and unfortunately, they were weaker and weaker and weaker, and the immune system goes low because they couldn't tolerate any food or medication or vitamins, so it was bad. Nowadays, we have a very good number of different classes of anti-emetic or anti-nausea vomiting medications that we can give them to the patient before, during, and after chemotherapy. With this regimen, the patient has minimal side effects. So even if I use high-dose chemotherapy, if I receive these medications either alone or in combination, the day or 2 days before chemotherapy, on the day of chemotherapy, and a couple of days after chemotherapy, for the most part, I'm fine. A lot of patients are even nausea-free, and that's great. In the past, we didn't have such a thing. In the past, the only class that was available was dopamine antagonists and also antihistamines. So can you name some of those agents for me? Dopamine antagonist, can you name a dopamine antagonist for me? When we talked about GI, we talked about those agents. Promethazine, metoclopramide or promethazine. These are anti-dopamine agents. In the past, we used to give the patient promethazine. Okay, that's fine, but it was not enough. Or we give the patient antihistamines. Again, promethazine is also antihistamine. Or diphenhydramine is the, antihistamine. They are good, but not enough. But these days, we have anti-serotonergic agents, plus anti-dopamine agent, plus anti-neurokinin 1 agent. All together have a very good care of nausea and vomiting. Question?
If it's anti-those, are they really sad then? Because their serotonin and dopamine levels are down? So would they be more depressed?
Oh, okay, very good question. So the question is, if you give the patient anti-serotonin medication, do they affect the levels of serotonin? No. If you give the patient a cetron, you remember ondansetron, any cetron, let's go to the next slide. So if I give the patient anti-serotonin agent for nausea and vomiting, it doesn't necessarily cause depression, okay? In theory, yes, it blocks the serotonin receptors. Even if serotonin is there, the receptors are blocked. A good thing about these medications are 5-HT3 is the type 3 serotonin is mostly in the GI. So they block the serotonin receptors mostly in the GI, not the CNS. But that's a very good thought. So, and these are not, basically these are not inhibiting the secretion of serotonin. These are just block the receptors in the GI, okay? Antidopamine, metoclopramide and promethazine. Again, we are not going to depress the patient. We are not going to induce depression. But at the same time, for your question, if the patient has Parkinsonism, Parkinson disease, then we have to be very careful. Because in Parkinson, even blocking the dopamine receptors can be very dangerous. Because in Parkinson, the issue is dopamine is not enough, or the receptors are not functional. So if your patient has Parkinson's disease, most probably the oncologist is not going to prescribe metoclopramide or promethazine. The oncologist is going to prescribe one of the cetrons or aprepitant or others. One of the newer classes that came to the practice was anti-neurokinin 1. About 15, 20 years ago, it came to the practice. Aprepitant is one of those agents. And neurokinin 1 is the receptor in the CNS that triggers the vomiting center. So if we block that, we prevent the vomiting. antihistamines are always very effective. So usually we use antihistamines in combination with other medications. So please know that all these medications are very effective to treat nausea and vomiting in cancer patients. Especially the first one, antiserotonergic, the third one, antineurokinin, and the others in combination with these. Mucositis, we talked about mucositis before, and this is one thing that is very important for you. The patients come to you if they develop mucositis. So after 1, 2, 3 courses of chemotherapy, they start having inflammation, bleeding, and pain. Very painful if they want to chew a medication, even if they want to drink medications, food. If they want to drink, let's say, tea or warm milk, it can be very irritating to their oral mucosa. A lot of patients get radiation and then they have xerostomia. We just talked about that, bleeding, inflammation. So there are some agents that we can use. One of the very first one is cholinergic agents. Cholinergic agent, they increase the saliva, so we can use them. In the case that radiation is so severe that the salivary glands are gone, this medication is not effective anymore. So pylocarpin is an option if the salivary glands are intact. We can also use a saliva substitute, sugar-free gums or candies or ice chips after chemotherapy to reduce the damage to the oral mucosa. Other agents that we can use, we had them before. In the GI session, we talked about these. So we use viscous lidocaine. What is viscous lidocaine? Local anesthetic. And it's a gel. Yeah, it's lidocaine gel. It's a local anesthetic. So it's anesthetize the oral, the mucosa. Basically, the patient doesn't have that much pain. Nystatin. What is nystatin? Antifungal. Because a lot of these patients have ulcers also. And they are very prone to have fungal infection, candidiasis. So we give them nystatin, diphenhydramine, antihistamine. I think you heard diphenhydramine 100 times, 200 times in this course. So diphenhydramine is one of the antihistamines, and a lot of this is inflammation. So we wanted to give the patient antihistamine to cool it down. Magnesium hydroxide, what does it do? Magnesium.
Stomach?
What?
Diarrhea.
Diarrhea? Diarrhea? Oh, diarrhea? No. Actually, you're right. It may cause diarrhea. If the patient swallow a lot of magnesium hydroxide, yes, you're absolutely right. So it's a one very good education point that if you prescribe this for mucositis, you want the patient not to drink it. Just swish and spit. Okay. It alkalinizes the pH. So if the pH is acidic, and if the patient already has a lot of inflammation, the patient has a lot of burning and pain. So if you give the patient magnesium hydroxide or Maalox or even Tums, any other antacid, if the patient can keep it in the mouth, it's like pain relieving agent. Sucralfate. What does sucralfate do? I'm asking this in the test. Ulcers. What does it do? Very good. It's a coating agent. So it's just like dressing. It goes on the ulcer and coat it. So if there is any acidic or irritating material, it cannot be damaging to the ulcer. Benzocaine is another local anesthetic, and you see there's a combination of steroid, hydrocortisone, antifungal, nystatin, and antihistamine diphenhydramine. We can use combination. We can use combination of any of these together. And chlorhexidine is an antibiotic. So for mucositis, we use this. You may also see these, amifostine and Gelcare. And these are very important for you because you may see these, or the dentist or you in future may recommend these agents. So please know that these are all treatment options for mucositis. Amifostine, Gelger. And the last one is palifermin. Palifermin, we usually reserve that for very severe cases of mucositis. Patients who are going for bone marrow transplant, they take a lot of chemotherapy, a lot of radiation. We inject them palifermin 3 days before, 3 days after bone marrow transplant. So please be familiar with the names of the medications we use to treat or prevent mucositis. Are you good? Can we keep going? I think in a few minutes we can finish. We are on slide 27 out of 41. We are good. Okay. When we are tired, let me know. We can stop and I can continue next week. We have good time. Dermatologic adverse effect. One of the major ones, you just mentioned that. Nausea, vomiting, and alopecia. These are the things that patients used to hate it. Hate chemotherapy because after a course, 2 courses of chemotherapy, they had hair loss, they had eyebrow loss, eyelashes. So it could be, especially for a female patient, it was very bothering. And it is, because still with cancer and chemotherapy, after a couple courses, this happened. But a good thing for patient to know and a good point for education for all of us. If you have a patient with cancer and they come to you and say, you know what, I'm very worried because I'm losing hair, a good news for them is what? Yes, it's grow back, maybe even more, different look. So someone with a straight hair has curly hair now, or the opposite. The color can be a little bit different, but it definitely grow back. So there is no chemotherapeutic agent that causes irreversible hair loss. So that's a good thing for them. Another dermatologic toxicity is, we call it hand and foot syndrome. And the reason is the patient who receive 5-fluorouracil or cytarabine, look at those 2 agents on the bottom, cytarabine or 5-fluorouracil, sometimes they get tingling or like needling, like they feel needles on the palms and soles, and burning sensation and pain. It's very, very sensitive, and usually a good number of patients cannot tolerate it. They cannot tolerate it to the point that we have to discontinue the medication and switch to another chemotherapy class. So the other name for hand and foot syndrome is palmar plantar erythrodysesthesia. Palmar plantar erythrodysesthesia. It's a kind of neurologic, dermatologic disorder. Happen with these medications. Treatment options, please know this very well. Topical corticosteroids, so we can give them topical steroids. Also NSAIDs, they can take PO, oral NSAIDs. It may help. If it does not help, we probably need to discontinue the medication. So if you give the patient all this medication, and even after those, the patient still has a lot of pain and burning on palms and soles, then you just have to discontinue possibly. Can you tell me, among these medications, ibuprofen, naproxen, celecoxib, which one is more COX-2 inhibitor?
Coxib.
Celecoxib, very good. Cox. So celecoxib is more COX-2 inhibitor. So which one has less GI toxicity? Coxib. So if you are going to recommend one of these to your patient with a history of GI bleeding, it would be the Coxib one. Which one has the more side effect of the GI? More side effect to the GI? Naproxen. And which one is average? Ibuprofen. It's not that good, not that bad. It's okay. So Coxib for patients with GI problem, naproxen we want to avoid in GI patients. Nephrotoxicity, I want you to know which medications, which chemotherapeutic agents cause nephrotoxicity, kidney damage. And unfortunately, this kind of kidney damage can be irreversible. So if we give the patient with ovarian cancer or colon cancer high doses of cisplatin, and we do not hydrate the patient, because the patient needs to be hydrated. Is this water?
Someone's
Can you
peeing over there in the back.
Okay. So when we are talking about these medications, we wanted to well hydrate the patient and give them electrolytes. So the patients are not behind the fluids and electrolytes. If we don't do that, cisplatin can cause irreversible kidney toxicity. And that's not good. So thinking about platinum agent, think about kidney toxicity. Another agent that may cause kidney toxicity is methotrexate. What methotrexate does is it goes to the nephrons, to the tubules, and it just stays there. Especially if the pH, if the urine is acidic, which usually urine is acidic, it just stays there. It just precipitate in the nephrons, like cement, and it's not good. To prevent that, we have to alkalinize the urine. We have to give the patient a lot of hydration and bicarb, sodium bicarb, to alkalinize the pH. This way, the methotrexate can get excreted from the body. Other toxicities of chemotherapy, the major one again, after nausea, vomiting, and alopecia, what patients hate and physicians very cautious about it, is bone marrow suppression or myelosuppression. After a few courses of chemotherapy, patients' red blood cells, white blood cells, and platelets go low. And this is dangerous. So all different cell lines get affected in the bone marrow. So less proliferation of white cells, neutrophils, lymphocytes, all cell lines get affected. These are the risk factors, of course, age, bone marrow reserve. If the patient already had radiation, it's even worse now. So these are the risk factors for damage to the bone marrow due to the chemotherapy. There are three medications that I want you to remember. Filgrastim, erythropoietin, and oprelvecin. Oprelvecin, we use it for low platelets. So if the platelet number goes low, if the patient gets thrombocytopenia due to chemotherapy, we give the patient oprelvecin. If the patient red blood cells go low, if the patient gets anemic because of chemotherapy, we give the patient erythropoietin. And if the patient gets neutropenic, it means the neutrophils are low and the patient is at high risk of infection, we give the patient filgrastim. So these are all growth factors. These are all proliferative factors that we give to the patient to treat myelosuppression. There are two major adverse drug reactions with erythropoietin. One is hypertension, and the other one is thromboembolism. So if you see a patient, and I'm sure in future you see patients on erythropoietin, there are subcutaneous injections. They usually inject 2 or 3 times per week. So if you see that in patient medication profile, think about two things: hypertension and thromboembolic event, blood clot. So if you have a patient on erythropoietin and you check the blood pressure is very high, it can be the adverse effect of the medication, erythropoietin. Let's go over, let's see, 2 more slides and then we finish for today. Hemorrhagic cystitis is another major adverse drug reaction, and it's caused by 2 agents. If you remember those nitrogen mustard, one was ifosfamide and the other one was cyclophosphamide. They go to the liver first and then they get metabolized to acrolein. Oh, did I say that here? Yes. Ifosfamide and cyclophosphamide. They get metabolized by cytochrome P450 to acrolein, and acrolein is a chemical which is extremely irritating to the bladder epithelium. So acrolein causes a lot of damage to the bladder epithelium. So if the patient receives high doses of ifosfamide or cyclophosphamide, like a lot of lymphoma patients or sarcoma patients, breast cancer patients, if they get higher doses of these agents, after a couple of days, they start to have bloody urine. So the urine is bloody, and they just excrete clots, big clots of the blood. Basically, the bladder epithelium gets sloughing. So it's very severe damage to the bladder. How can we prevent that? Hydration again. Hydration, and I don't know if I mentioned that or not. Okay, so I don't ask this because I didn't mention. And there's an antidote for that. But just make sure that you know if you are giving the patient ifosfamide and cyclophosphamide in order to prevent or minimize the risk of hemorrhagic cystitis, which is damage to the bladder wall, we need to hydrate the patient. Okay, signs and symptoms, just blood in urine and sloughing of the bladder epithelium. And sometimes because of the blood clots, the ureters get obstructed, so we have to put a catheter to remove the blood from the bladder. But again, hydration can prevent it, and also there is a antidote that most probably next week I talk about that because it's important for you to know. If you give that antidote to the patient, the risk of hemorrhagic cystitis is much lower. Okay, I think we had a good number of medications name and information about adverse drug reaction. But if you go back and you can look at the names, a lot of them are easy to put in the class, like platinum or phosphamides, or let's say vincristin, vinblastin, those medications. Okay, any questions for me? Good luck with your exam. Oh, question?
Case studies next week.
Yes, case study, if you look at the schedule, is scheduled for next week. So next week we finish this, we have another lecture, and we have case study. Great, thank you very much. Have a good day. Thanks. How many questions do you have for the test?
Is it 40?
Oh, 40?
For the final?
No, for
For
the this coming exam, next hour.
Oh, like 40 years.
40.
Super, yeah.
Okay.
Está lloviendo. Lloviendo. Not lloviendo. Okay.
Let me say so many people, then I will start.
Steve, so many people. Oh, okay. Do we have lecture? Oh, we don't have lecture today.
Brian,
Yeah.
you're recording
Yeah.
today.
You want to see it?